Neurology at Mayo Clinic in the Movement Disorders program at Mayo Clinic, Scottsdale, Arizona. So primarily I work as a clinician, seeing patients all day, but I also spend some time doing research, and I'm just a small part of a large team that does research. That's a collaborative project here at Sun Health Research Institute, Mayo Clinic, and as well as folks from Banner, and it's a large consortium. So I'm very, very happy and privileged to be a part of that group. I want to take this opportunity to thank Sarah and Judy and the PMD Alliance for organizing such a great conference and inviting me to speak. And also thank you, ladies and gentlemen, for coming here today on an early Saturday morning. I hope the information that you get here today, you find it useful. So, without no further ado, I'm going to get started. So, I was delegated the task of talking a little bit about the research that's ongoing in the field of essential tremor. So I'll just very briefly hit on the clinical aspects of tremor, but I will not get too much into the existing treatment of essential tremor. My colleagues are going to do that, so I'll just kind of focus more on what's on the horizon and some of the new things that may be coming down the pipeline. Okay. So, as you all know, essential tremor is known by a few other names, such as familial tremor, benign essential tremor. In the past, it used to be called senile tremor. We no longer use that term to be politically correct. So, just before we start, how do we define essential tremor? So it is basically characterized by a rhythmic shaking which occurs during voluntary movement, so an action tremor, or primarily with voluntary maintaining of a posture or a position, such as a postural tremor. It is usually less common at rest. So, for example, one of the other common causes of tremor is Parkinson's disease. That you see more commonly at rest. Having said that, I've seen a multitude of patients where when the essential tremor is so severe, or they have had it for a very long time, I may see it even at rest. So having the tremor at rest doesn't always mean that it's Parkinson's disease, whatnot. In severe essential tremor, it can spill over into being present at rest as well. As you all probably already know, the two salient features, or the two common things that are associated with essential tremor is, one is the response to alcohol. I've heard from many a patient that they themselves notice it if they've had a drink or two, their tremors tend to calm down. And also family history is very common in essential tremors. So they'll have a first degree relative, either their parent or they notice their children also start having a tremor at a young age. So how common is essential tremor? It is one of the most common causes of tremor. Prevalence across all ages is about 0.9%, and for folks over the age of 65, it's much more common, in about 4.6% based on the epidemiologic studies that have been done. And it's unfortunate that even in this day and age, that there are folks out there who have this tremor, and it does cause significant problems to them, but they kind of just live with it, or it's not brought to the attention of their primary care doctor, etc. About 27% of people with tremor, and these are studies that were done in Germany, and even the studies done here in the United States kind of mirror the same result. About 27% of people only seek medical advice in regards to their tremor, and out of those, only 8.3% have been prescribed a medication to treat their tremors. Now, I understand, apprehension related to medications, whatnot. I mean, I don't it's my personal philosophy not to push medication on patients when I see them, because if the tremor is not bothersome and if it doesn't interfere with their activities, why expose them to medication and side effects, etc., that come from their own. But if the tremor causes problems, then I really advocate treatment. As you all know, these are some of the problems that are associated with patients who have an essential tremor. Interferes with their handwriting, it can interfere with eating, drinking tasks, dressing, even speaking, because voice tremor can also be a part of the whole essential tremor syndrome. And it's not uncommon when I hear patients say that, I've stopped going out much, whatnot, because I shake a lot, and when I go out to a restaurant, people look at me, and so there is some degree of embarrassment that folks feel, which is unfortunate, and hopefully with the right treatment, we can mitigate that. So again, as I said, I'm not going to delve too much into the clinical aspect of tremors, but just these are the two most common form of tremors that we encounter in the clinic. Essential tremor and the tremor associated with Parkinson's disease. Again, there are quite a few distinctions between these two type of tremors. In ET, it's most commonly head, voice, hands. In PD, they can have it around their mouth and hands. It's usually asymmetric in Parkinson's disease, but in essential tremor, usually the onset is bilateral and is symmetric. Again, essential tremor can be very long-standing. In Parkinson's disease, the duration is fairly short. Family history tends to be a very prominent feature in essential tremor, not so common in Parkinson's disease. As I mentioned earlier, alcohol responsiveness is quite commonly noticed in essential tremor, not so much in, again, the tremor associated with Parkinson's disease. As I mentioned earlier, the tremor in Parkinson's, initially at least, is mostly present at rest, and maybe also slightly present with posture and action. But in essential tremor, it's mostly with action, eating, drinking, writing, or with posture, holding a newspaper, reading a book, things like that. The medications used to treat these two types of tremors also are quite different. As you know, beta blockers such as propranolol or primidone tend to form the first line of treatment for essential tremor, whereas dopaminergic medications such as Sinemet, carbidopa, levodopa, or other forms of dopaminergic medications are what used to treat Parkinson's disease. Also, the handwriting problems that patients experience with these two different forms of tremor are quite different. As you can see, with essential tremor, it's the tremor interferes, so it's fairly illegible, and it can distort the handwriting to a significant degree. In Parkinson's disease, it's what's noticed is it's called micrographia, where even though the patient may have tremor, it doesn't interfere usually with the handwriting, but as they continue writing, the handwriting becomes smaller. So that's what we see in Parkinson's disease. So now, moving on to, I want to some of the research findings in essential tremor. So that's what we'll focus the rest of the talk on. So one of the issues that is being hotly debated in the literature and at various conferences is about essential tremor and neurodegeneration. So is essential tremor a neurodegenerative disease? So we know, tremor forms a prominent part of the symptoms that patients with essential tremor experience. But do they have other issues that may form the constellation of the essential tremor problem that we may not be recognizing? So one of the questions that has been asked is it associated with cognitive decline? Now, understand that it's tricky, because again, essential tremor is much more prominent becomes much more prominent as we age, and cognitive decline can also occur as we age. So, the trick is to dissect these issues out and see if folks who have essential tremor, are they at increased risk of having cognitive decline or developing dementia in the future as compared to similar aged individuals who do not have essential tremor. So basically that's the question that is being asked in the research community. Also, is essential tremor associated with other neurodegenerative diseases? So if somebody has essential tremor, and in a young age they do fine, but as they age, are they at increased risk of developing other neurodegenerative diseases like Parkinson's disease, for example? There are some, believe it or not, there are a few people in the research community who believe that might be the case, although the data to support that is very weak, and we will get into these issues. And as I said, some do believe that might be the case, but our data doesn't support that. So, and I'll get into that in a second. So first, I really want to pay my respects to the community out here in Sun City because they're a big part of this Arizona study of aging and neurodegenerative disease. This program, which I form a very, very, very small part of, has been going on since 1987. It initially started with brain banking. So, there's very few places in the world where we can clinically study patients, follow them through their life on an annual basis, monitor their symptoms, as well as monitor their cognitive function as they age, and when they pass on, they donate their brain and body for studies to the Sun Health Research Institute, and we're able to correlate how they did all through life to actually the degree of brain damage, what areas were affected, what not. So that is a very, 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 that's the gold standard, and that's a very unique and a rare program to have. There are not too many places in the world that have this, and the research and the data that has come out of this program here, thanks to you guys, has helped research all over the world. I can't tell you, and I am a new addition to this program, but some of my senior colleagues, they've not only have they presented this data all over the world, but other people have learned so much from this data. So I really wanted to take a minute to pay my respects to the community out here. Again, this research effort has been funded by IETF, the International Essential Tremor Foundation, also funded currently by NIH, in the past by ABRC, Michael J. Fox Foundation, and also through the Mayo Clinic Foundation. And so moving on to the first research question, about cognitive decline. So are patients who have essential tremor are at increased risk of developing dementia in the future, whatnot? So this is our data with incidence of, we studied incidence of dementia over a 10-year time period. And in 83 subjects with essential tremor, that's the graph in black. And the controls, these were about 400 subjects without essential tremor, that's the graph in gray. So as you can see, there is a lower incidence of dementia in folks who have had essential tremor as compared to folks who did not have essential tremor. So this data at least suggests to us that there isn't an increased incidence of dementia in essential tremor.
Good.
Yeah, that's great. Also, this slide depicts the data that we've collected based on neuropsych testing. So neuropsychological testing is, I'm sure many of you may have undergone that. You know, it's kind of a grueling test. You know, it takes a few hours where they put you through various aspects of memory testing and other executive brain functioning. So in about 120 subjects with essential tremor and 534 controls, there was no difference in the neuropsych testing. As you can see, MMSE is a test that we use in the clinic just to quickly assess memory problems, mini mental state exam. And some of these other, the clock drawings, troop interference, controlled or COVAT, controlled oval word association. These are test-to-test verbal fluency. Some of these tests, auditory learning, learning strategies, things like that. So on all of these tests, based on the neuropsychological battery, there was no difference. In fact, with the auditory visual learning test, some of the folks with ET did better as compared to the controls. So, you know, this is good data that suggests that there isn't increased cognitive decline or dementia associated with essential tremor. And so, now the next question, is it associated? So I think we have a pretty good understanding that it's not, it doesn't, people who have essential tremor are not at increased risk of developing dementia, whatnot. But is this associated with other neurodegenerative diseases? Alzheimer's disease, or even a Lewy body formation, which can occur in idiopathic Parkinson's disease. So, because there is some literature out there that suggests that patients who have ET are at increased risk of developing Parkinson's disease in the future. So, you know, we wanted to take a good hard look at that, at least based on our research data. There was no increase in Lewy bodies in 24 autopsy ET patients. Now, I understand that the number is small, but again, it's, you know, this kind of gold standard information is hard to come by. And so this is really very meaningful in the sense that, because it doesn't correlate just based on ante-mortem or in-life diagnosis. So we correlate their clinical symptoms to autopsy, so based on actual pathology after they pass on. So that is truly the gold standard of diagnosis. So there was no increase in Lewy bodies in the ET patients. So Lewy bodies is a hallmark. Increase in Lewy bodies, especially in certain areas of the brain, is a pathological hallmark of Parkinson's disease or dementia with Lewy bodies. So these are some other neurodegenerative diseases, and we did not find that. Also, patients with incidental Lewy body disease. So again, in our cohort here, this group of patients were ones who in life did not, when they were alive and going, you know, they did not have any signs or symptoms suggestive of Parkinson's disease. But when they passed on and we studied their brains, they did have more Lewy bodies in their brain than, and in areas that we would find in Parkinson's disease. So that's why it's called, this group is called incidental Lewy body disease, because they did not have clinical signs and symptoms of Parkinson's disease. So they cannot, Parkinson's disease is a clinical diagnosis, so they cannot be diagnosed as Parkinson's disease. I hope I've made that clear.
What's Lewy bodies?
Yeah. So Lewy bodies is, so these are abnormal accumulations in the brain of proteins or clumps of proteins, and they are a hallmark of Parkinson's disease. So what happens is, in Parkinson's disease, and again, I'm generalizing here, is there's an abnormal protein, alpha-synuclein, that accumulates in the cell. The cell cannot dispose of that in an appropriate manner. And that forms clumps, and it leads to aggregates, and that can lead to cell death. And once enough neurons are lost in certain areas of the brain, it can lead to clinical symptoms of Parkinson's disease. So basically, from a pathologic standpoint, Lewy bodies is like the marker for Parkinson's disease, or a marker for neurodegenerative. Again, they were also patients with essential tremor were not no more likely to have Alzheimer's disease pathology or PSP, which is another neurodegenerative disease called progressive supranuclear palsy. So at least in our cohort, in our population that we studied, ET was not associated with any other neurodegenerative disease. So then that brings up the next question. Is ET, or essential tremor, its own neurodegenerative disease? Again, the evidence, so there is a very highly respected group up in Colombia, and they have done similar studies. They have also, they follow patients and have had studied them at autopsy and done pathology. So again, I mean, this is a very credible group, and their data suggests yes, because they found some increased cell loss, a particular type of cell called the Purkinje cell fibers, in a particular part of the brain called cerebellum. They found that patients with essential tremor had increased a loss of that particular type of cell called the Purkinje cell. Again, our data says no. We've also studied this particular area of the brain looking for increased loss of this cell type. We did not find that in our group. And also another group in Canada that does similar research, their data coincides with ours. Their findings were similar to ours, that they did not find that essential tremor patients had increased Purkinje cell fiber, Purkinje cell loss also. So, but again, this is being hotly debated in the literature. So this is our data. As you can see, there was no difference in Purkinje cell density in essential tremor patients between our patients and the controls. So controls being folks who did not have essential tremor. But I think we'll learn more about it as more time goes on. But at least right now it seems that, or that's what we believe, that it's not a progressive neurodegenerative disorder, essential tremor. And also, it's not, with this kind of research, and the evidence it's still ongoing. I think the jury is still out, the verdict is still pending. But we also have to factor in, slight differences in the population, slight differences in the methodology of collecting the information. So there are quite a few caveats also that we have to keep in mind. That's why I think this issue will be clarified further going forward as we have more numbers and as other groups have more numbers also. And I know this is coming on to the last part, and I wanted to spend a little bit of time with this, is treatment, because I think that's what most folks are interested in from the standpoint of clinical treatment, or what's on the horizon that's going to help us in the future to treat our symptoms. So, there's been a lot of small studies using several different drugs. I'm not going to get into all the failed studies or things that looked promising at the outset, but then unfortunately did not see the light of the day. By and large, we know, anti-seizure medications are a good group of medications that have been studied. Some of them have been very successful and are being used to treat the symptoms today. Again, Dr. Liu is going to elaborate more on that, but primidone or mycelium that many of you may be on or may have been on at some point was an old seizure medicine. Gabapentin, topiramate. These are all seizure medications that have known to be helpful in essential tremor. So, the group of seizure medications lends itself easily to research, to be studied, to see if, a new seizure drug that comes out, is it helpful to treat tremors more so than the existing ones that we have right now. So there's this one study that's ongoing, perampanel. This is again a medication that has been FDA approved as an adjunct or as an add-on therapy for other seizure medications. It's marketed as Fycompa, so it's commercially available. But there is an ongoing study looking at this medication for any possible benefit in essential tremor. It's being done in the LA area. We don't have any sites around here, but we'll watch for those results. Another study with octanoic acid. This is an interesting one because this is not, while the study is new, this drug or the interest or our interest in this agent is not new. So it's, we talked about alcohol being helpful for essential tremor, right? So this is kind of a derivative of alcohol without the getting drunk effect of alcohol. So, which is like, then why the hell do I take it? No, I mean, jokes aside. So that's what this drug is, and it has been studied in smaller numbers a few years ago too. Actually, this paper was published in 2013, where in 19 subjects they looked at put people on this drug, and they had a control group. One of the primary endpoints, or one of the outcome measures for the study, was the primary endpoint was to see an improvement in the tremor at 80 minutes versus placebo. So one group gets the drug, other group gets the placebo, the sugar pill, and to see at 80 minutes if there is a difference. The group that got the drug, were their tremors better as compared to the group that got the sugar pill? At 80 minutes, there was no change. They did not find any improvement in the dominant hand tremor with this medication as compared to placebo. However, it did improve later on at further time. So at 180 minutes, there was improvement in both hands as compared to placebo. And this benefit was maintained even further out at 300 minutes. So because the study did not meet the primary endpoint, which was improvement at 80 minutes, the study was technically a failure. But I just wanted to share this data with you. Currently, there is an ongoing study with this drug to look in voice tremor, to see if it improves voice tremor in patients. And we'll learn more about it going into the future. These are two other ongoing studies. Again, they don't have a name, just compounds. ST101, this is an agent that is an acetylcholine release agent. So it's being, the initial studies were in Alzheimer's disease to see if this drug would actually improve the symptoms of Alzheimer's. But we're now looking at it to see if it actually does improve tremors also. Because, like you see with so many drugs that are actually being used now, they come into prominence for some other reason, and then once folks start using it, or in the initial studies, you see that, wait, it also helps tremor or something else, and then, the research proceeds in that direction. So we'll see. It was originally being studied for Alzheimer's, but there's some interest of looking at the efficacy of this drug in Alzheimer's disease, in essential tremor as well. Sage 547. This is Sage is a company that owns this molecule 547. They have this drug, and I don't know much about it except because it's industry funded study, so they tight-lipped about it a little bit. But again, that is being investigated in essential tremor also. So if it's positive, we'll know about it in the upcoming few years. I'm sure many of you may have heard about this because there's a lot of buzz being created, and also in the social media, in the news, in the general media as well, about some of these new surgical approaches for, or non-surgical approaches for essential tremor. So, from a surgical standpoint, and I'm not going to talk about this, but we know in the past we used to do what was called a thalamotomy, where make a lesion in a particular area of the brain called the thalamus or the VIM nucleus of the thalamus, and we knew that would help, and that helped the tremors. Then that evolved into what we currently do or use today is deep brain stimulation that Dr. Pujakal is going to spend a significant amount of time talking about, which is where we implant electrodes in the brain and we can program them, and we know that helps tremor to a significant degree. So that is, that has been now, it's FDA approved, has been used clinically for at least past 2 decades, and is becoming much more common now. But for patients who are not good surgical candidates, for patients who cannot undergo surgery, for that small group of patients, in the past we used to recommend that they go to non-surgical radiosurgery. So it's stereotactic radiosurgery in the form of gamma knife. Again, I've had some very limited experience with it, but I think as technology has evolved over the years, I think it has gotten some better. But you're hearing more and more about it now as the number of patients going through this grow. Outcomes with gamma knife in the literature have been comparable to deep brain stimulation. However, there are significant complications associated with it. There are 2 points that I want to make sure that everybody goes home with. One, it's still a form of lesioning. So with gamma knife, it's non-surgical, so there isn't an incision. So it's non-surgical, but it is still a form of lesioning. So what they use is very targeted radiation to basically make a hole in that part of the brain. So once a lesion is made, it's irreversible. So that was the other point, that it is irreversible. It takes about 3 to, on average,